through there. So it's pretty important for us to have a good transcripts picking on background as we start this program, because a lot of these things are now going to be your decision. There's not a fallback system for figuring out what rhythm your patient's in every time it changes. If it's something you can deal with long term, you can call cardiology, you can get 12 leads, that sort of thing. But acutely, you're going to be responsible for figuring out what's going on and addressing it. So there's two types of cells in the heart. We're just going to do a quick anatomy review because this is pretty important as it pertains to what actually happens as far as the cardiac conduction and recognizing things from an electrical standpoint. You have pacemaker cells and contractile cells, and that's exactly what they do. So it's pretty easy to remember. And it's kind of cool because the heart has its own ability to generate spontaneous action potentials without any sort of external stimuli. It's a good thing and a bad thing. When it works the way it's supposed to, it's a good thing. When it works the way it's not supposed to, think about somebody in like ventricular fibrillation or ventricular tachycardia, where those pacemaker cells are all doing their own thing. It can obviously cause problems for you. Other things that kind of come into play there, if you think about the difference between the normal cardiac conduction cycle as it follows that electrical pathway, and we have an organized rhythm, you also get organized contraction. When you're outside of that, think of ventricular fibrillation as kind of the worst case, because each of those is a separate pacemaker cell firing independently, as opposed to like ventricular tachycardia, where you have one pacemaker cell that's taken over and it's firing. You can see how that results in ineffective contraction and therefore loss of cardiac output. In the rate and kind of how things process through there is also another key thing for you to remember. You're going to see that there's a couple slides where I keep kind of reiterating that heart rate, because as you start doing EKG interpretation, that's a good guide for you. Not only the morphology of the complex, but looking at the heart rate. That's also a good reference point for you to try and figure out the origin of the rhythm. So it's very important for you to know that. And then finally, the last thing I'm going to say kind of as we move through that, you have got to know the rules for EKG interpretation. If you've always gotten by just kind of looking at things and guessing what the rhythm is, you're going to be in a rough situation here, because EKG rhythms can change very quickly, but they can also change very subtly. So you need to make sure you're aware of the subtle differences between ST elevation as you would see with an MI, or T-wave elevation like you would see with hyperkalemia. So we're going to talk about just the EKG rhythm part today, and then we're going to move on to 12 leads next week. So as far as pacemaker cells, the primary ones we see are associated with the SA node, the AV node, the bundle of His, the right and left bundle branches, and then finally the Purkinje fibers. And that's the traditional conduction system we follow. It's when we start to have trouble with strange pacemaker cells or kind of independent pacemaker cells that we start to see PVCs, PACs, PJCs, and then eventually potentially atrial fibrillation, ventricular tachycardia, or ventricular fibrillation. So the second type of cell we look at are the contractile cells, and they make up the bulk of the myocardium. It's about 99% of it. And these cells are responsible for the actual contraction of the heart. So it's very important that you have that conduction system from the pacemakers that then trigger the contractile cells to actually cause the heart to do what we want it to do, to contract. So we're going to start a little review of electrical conduction, and I'm sure when Dr. Schmidt gets to this, he'll go over it in great detail. But what you see happen is that for some reason you have stimulation above threshold, and the sodium channels, which you'll remember are the kind of the fast channels, cause cell-to-cell conduction. So as that happens, you start to see depolarization from those cells, and it goes from one cell to the next to the next. When that happens, you have a release of calcium into the interior of the myocytes, which then causes contraction. As that happens, you simultaneously, or immediately thereafter, have potassium outflow, which then causes repolarization. So keep in mind as we start talking about treatment for things, how important the calcium and potassium are for that reason. Because if you have abnormalities of one or the other, you're going to have ineffective contraction of the heart. So you think about somebody with hyperkalemia, because of that imbalance, they're not going to have very effective electrical activity as well as physical contraction. So you kind of have to maintain a functional succinctum where they're able to live in a happy balance, if you will, allowing things to work the way we want them to do. All right, so starting at the top of the heart, we have the SA node. General heart rate in your SA node is going to be between 60 and 100. So if we're referring to any sort of normal complex, think about our normal sinus rhythm, if you will, that heart rate should be 60 to 100. So that's our traditional conduction rate. When you start dropping further down in things, you will see that the heart rate tends to drop. So things for you to keep in mind when we're talking about the SA node. There's definitely things that can cause heart rate increases and still be perfectly normal. For instance, if I have some sort of sympathetic stimulus, I will see the heart rate increase by stimulating and activating the beta receptors. On the other hand, you may have some sort of parasympathetic stimulation that causes the heart rate to slow down. What's the largest parasympathetic stimulation we see? And if you think about how we treat patients whose heart rates go down, it'll help
vagus nerve stimulation, like vagal maneuvers?
Exactly, vagus nerve stimulation. That's the biggest one we see that affects our heart rate. So how do we treat vagus nerve overstimulation that's causing decreased heart rate?
Atropine.
Atropine, exactly. So if you think about atropine, just remember it's a parasympathetic blocker. So it's blocking out that excessive vagal influence. Now, that may not be the reason for the bradycardia, but it is something for you to keep in mind as you start thinking about what may be causing it. So shifting back to the SA node, as I said, generally your heart rate's going to be about 60 to 100. We oftentimes will refer to a normal sinus rhythm as falling in that 60 to 100 range. That's a term I generally avoid if I can, because even though it may be in a normal heart rate range, it's not uncommon that you have some sort of aberrant conduction or something that's a little bit outside of the normal mean. So I generally just call it a sinus rhythm and then give the heart rate. Likewise, if you have a sinus tachycardia with a heart rate greater than 100, it's still a sinus rhythm. It's just a sinus rhythm at a heart rate of 110, what have you, or a sinus bradycardia being less than 60. So I generally avoid the normal comment if at all possible. So as you move through that, we start off with our stimulation of the SA node. And as the action potential travels down through the atria, you're going to see the atria depolarize. So that electrical impulse is traveling down through there. And then it contracts. And as it's doing that, those cells are going to push the blood down into the ventricle. That's going to occur during diastole. So one of the things for you to think about here when you're looking at an EKG, what represents the depolarization of the SA node? Anybody know? Think about what you see as far as your atria on an EKG.
The P wave.
Your P wave, exactly. So you see your P wave, and that's that electrical impulse traveling down through the SA node. When do you see repolarization from the P wave or from the atria?
It's hidden in the QRS.
Good. So if you've read ahead, the answer is in there, but you won't see it because the QRS is a much more predominant complex. All right, so the next thing we have to talk about is internodal pathways. Because what happens, the SA node generates that impulse at that rate of 60 to 100, and then it's got to travel somehow through the right atrium to the left atrium. That's generally going to be through Bachman's bundle. You can see it kind of carries over there. With that being said, you'll see that there are a lot of aberrant conduction pathways that develop in patients. And this is how we get involved a lot of times, is they may go to the electrophysiology lab as we're trying to figure out exactly what's going on and address those issues. So even though this is what's supposed to happen, it doesn't mean that's exactly what's happening. So it's going to travel from the right atrium to the left atrium by Bachman's bundle. And then the other thing you're going to see is that through these internodal pathways, that it kind of travels on down through the atrium. So moving along, we traveled down through the atrium, and now we've gotten to the AV node. And the inherent rate in the AV node is 40 to 60. So if you think about it, up top we were at 60 to 100. We've now traveled down through the atrium to the AV node because it sits right on the border, and our heart rate's dropped. So if I've got a patient that's in a bradycardic rhythm, I want to start thinking that perhaps it's coming from something a little bit lower down than the SA node, and it could be coming from the AV node. It generally sits right at the base near the intraventricular septum. And kind of think about this as the gatekeeper. So this is what controls the action potential from the atria to the ventricles. So when you start thinking about AV node blocks, like a second degree, third degree, first degree, your gatekeeper there is stopping the impulses or not allowing the impulses to travel through exactly the way you want them to. The other thing for you to keep in mind here, if you look at that EKG strip, is that this is the end part of your PR interval. So you won't necessarily, sorry, the screen just went crazy there. So that's where your PR interval ends, because right after you go through the AV node, this is when you start triggering the ventricular impulses. So your atrial activity is essentially done. You're now transitioning over to a ventricular component. Similar to the SA node, you'll see that the AV node has a lot of pacemaker cells that have their own ability to generate spontaneous action potential. The big difference between the two of those is that the pacemaker cells at the AV node are at a much slower rate. So that's why you have that heart rate of 40 to 60 as opposed to the rate up above of 60 to 100. Are you guys not able? Oops, sorry. I don't know what it did. Thank you for letting me know. Is it back there now?
Yes.
Okay, I'm not sure why I just tripped out there. So because of that slower action potential, the AV node rate is again going to be 40 to 60. But what you do see is that because the SA node provides the action potentials at a much higher rate than the AV node, the SA node depolarizes the pacemaker cells within the AV node before they have a chance to spontaneously depolarize. So it's following that pathway as opposed to initiating impulses on their own, which is exactly what we want. So with that in mind, remember that the SA node is going to be the primary pacemaker of the heart. The AV node is kind of your secondary pacemaker. For some reason, your SA node isn't functioning the way it should be, or because that internodal pathway, the impulses aren't getting down to the AV node the way they should be. The other thing that you see, as we talked about, is that the AV node slows down the conduction velocity of the action potential. This is really an important function because by slowing down the action potential, it gives time for the atria to contract before depolarizing and contracting the ventricles. If you lost that balance between the two, you would lose the ability to have that effective contraction because you wouldn't be loading the ventricles up before you contracted and squirt that blood out into the lungs. So it's very important that we maintain that system. And that's why I said that kind of gatekeeper principle exists where you're able to slow the impulses there to allow the atria to depolarize. So the next thing we do is get down to the bundle of His. And it transitions from our AV node down into our left and right bundle branches. It travels to the intraventricular septum. And it also kind of has its own inherent heart rate. Usually it's going to be about 40 to 60. And then as you get down into the bundle branches themselves, you see the heart rate drop even lower. So if I have a rhythm that presents with a rate of 20, 30, 40, I want to start thinking that that rhythm may be originating even below the AV node. It may be actually coming from the ventricle itself. So if you think about somebody that's potentially in a idioventricular rhythm or a rhythm that originates in the ventricles, a lot of times that rhythm is going to already be slow. So if I have somebody with an idioventricular rhythm that has a heart rate of, say, 80, it's what we call an accelerated idioventricular rhythm because it's occurring from the ventricles following that ventricular pathway only, but it's above the normal rate for what you see inside the ventricles. Same thing if you look at a junctional rhythm. So the rate at our AV junction is what? 40 to 60, right? So if I have somebody that's in a junctional rhythm at a rate over 60, it's going to be an accelerated junctional rhythm because that's above the intrinsic rate of that AV node. All right, so getting back to the bundle. So our conduction goes from the AV node and then it goes into the bundle of His, which, as I said, sits in the intraventricular septum. It's comprised of all those pacemaker cells that is have their own potential. So you could see a rhythm originate there at that rate of 40 to 60. So from there, it's going to then travel down into the right and left bundle branches. This, especially when we start talking about our 12-lead EKGs, becomes kind of a big deal because you might start to see bundle branch blocks or conduction delays in either the left or the right bundle branch. When that occurs, instead of seeing one easy QRS complex, you may actually see different ventricular depolarizations because that delay or that bundle branch block has created a timing inefficiency where you're able to see maybe the right side before the left side or vice versa. Don't worry about that so much for this lecture. When we get into the 12 leads, I'm going to show you kind of an easy way to figure out whether it's a right bundle branch block, left bundle branch block. But the other thing for you to take away from that is if you do have some sort of bundle branch blockade, your QRS complex may be easy to differentiate as having two R waves. But the other thing is a lot of times that QRS complex will be larger. So you'll see kind of a big QRS complex because it's taking longer for that impulse to travel throughout the ventricles. All right, so as we continue further down into the bundle branch blocks, or into the bundle branch, obviously the right ventricle is depolarized by the right bundle branch block, and the left bundle branch depolarizes the left ventricle. And they're going to have that intrinsic rate of 20 to 40 beats per minute. So finally, we get down through our bundle branches, and we get down to the Purkinje fibers. These are those last ventricular fibers that are sitting down there. And these are kind of in an interesting situation, because what they do is instead of spreading impulses via the traditional pacemaker cells, you actually see that a lot of times they spread the impulse by the contractile myocytes. So it takes a long time for that impulse to go cell to cell to cell to cell to cell, as opposed to following kind of the traditional conduction pathway that we're used to. So again, when you start thinking about those longer transitions or those longer travel times, you're going to have larger QRS complexes. So anytime you see a big QRS complex,